Good afternoon, everyone. Good afternoon. Good afternoon. It's great to see you here today. So I'd like to welcome you to the inaugural Chancellor's Distinguished Research Lecture. We are delighted to have you here and to celebrate Donna Dabelea, which we'll be doing in just a few minutes. Just to make a comment, we've got a tradition on our campus of inviting in outside distinguished lecturers. We've done this for years. I think oftentimes in this very room, we'll have researchers from around the world, around the country that will come here and speak to us. And I have partaken in many of those lectures. And frankly, I think they're oftentimes fantastic. And it's a wonderful tradition for our campus to do that. This is something different, but builds in the same theme. Today, we're going to start the tradition of honoring and recognizing some of our very own distinguished faculty. And again, we're delighted that Dr. Dabelea will be the first one that does this. This will be a chance to celebrate her career, her accomplishments, and also to learn from her. And this process started about a year ago. We announced the award and we looked at applications and had our committee in place. And we had a lot of interest in this award, a lot of applications and a lot of very, I think, worthy people for this award. David Schwartz and Donna Dabelea were the two that were named. You're going to give the talk today, and David will give his talk in February. So with that, we're starting this tradition. I'd like to invite the Chancellor to come make a few comments as well.
I'm not as tall as Tom. This is called the Chancellor's Distinguished Research Lectureship. It really ought to be called the Tom Flagg Research Lectureship. It was his idea. And when he brought it to me, I said, what a great idea. I remember, oh God, pretty early on in my tenure, going to a panel of our cancer docs, MDs and PhDs. And they spoke to a group of donors and thought leaders, as part of that series that we have. And at the end of it, there were, I think, 4 people or maybe 5 in the panel. They stood around talking to each other, and the number one statement was, God, I didn't know you were doing that. I mean, it just brought home the fact that there's so much going on in this campus that is so interesting and fascinating, and most of us don't have a clue what other people are doing. It's a mission of ours to try to attack that opportunity, because it is an opportunity. And I think this lecture series of which Donna is the appropriate inaugural speaker is one step in that direction. So I'm thrilled that Dr. Flagg came up with the idea, and I hope that you're looking forward to the next few minutes as much as I am. So thank you.
Thank you very much for this honor. Not this. I want to start again by thanking Vice Chancellor and the Chancellor for this amazing award. Above all, I would like to thank and express how honored I am for having been nominated and having been selected for this award by my peers. It's an incredible honor for which I'm extremely grateful. So thank you very much, and thank you for being here today. How many times, how often do we have a chance to talk about ourselves? I'm going to take that chance and tell you a little bit about me. So I was born and raised in Timișoara, Romania, and I completed there MD and a PhD in that part of Eastern Europe that some of you know as Transylvania. I had the opportunity to then stay in academic medicine as an assistant professor at the University of Medicine and Pharmacy in Timișoara for a number of years before being able to cross the pond and arrive in Phoenix via a fellowship with the epidemiology branch of NIDDK, an intramural a group that studied diabetes. And after 2 years there, I was also fortunate enough to be recruited to join the University of Colorado Preventive Medicine and Biometrics Department in the School of Medicine, where I was an assistant professor for a number of years. So I started all over. But then I became professor in the School of Public Health and director of the Lead Center, distinguished professor in 2021, and associate for research for the Colorado School of Public Health just this year. So I want to highlight a little bit my formative years, my Romanian journey, because I think that you might recognize some themes that continue throughout my careers with appropriate changes, of course. But as I said, I was born and raised in Romania. I attended medical school. The first picture here is my medical school in Timișoara. I was the class of 1990. I completed a residency in internal medicine and another one in diabetes, nutrition and metabolic diseases, and a PhD in clinical sciences. And then I stayed there as an assistant professor. You see there a picture with me and residents and students doing clinical work, which I've done, doing some teaching, both students and residents and fellows, and then doing some research. I mostly did small industry-sponsored studies at the time, but I also was involved in establishing the first Romanian type 1 diabetes registry in the country, with which we participated in international studies such as EuroDiab or Diamond. So it's easy in retrospect to see the links to what I'm doing today. I never thought at the time that I was going to continue to do, registry work in the United States. But these were my formative years, and these are part of who I am. Then came my transformative period, and it really was a transformative period, which made me think of changing my life completely, not just my career, and coming and staying in the United States. So I completed this postdoctoral fellowship with the intramural NIDDK branch in Phoenix, Arizona. And what you see here is our pictures of two of my mentors, Peter Bennett on the left and Bill Noller on the right. These are titans of diabetes research. And I'm most grateful for everything that I know to these two folks here. You're also seeing a picture of me in front of their research building in Phoenix, which, for those of you who knew where the Lead Center started in Building 402, it has a lot of resemblance. And on the right is the Huhuka Memorial Hospital on the reservation in Sacaton in southern Arizona, where some of the studies that I was part of were conducting, including I collected data for the diabetes prevention program, which I now lead after 20-some years, 30-some years. Transformative years indeed. What they were special about was they conducted the Pima Indian study, which is a landmark study in the field of diabetes. It went on for almost half a century, really. And I don't know, most of what we know about diabetes comes from this study. And I was fortunate enough to be part of it. Again, you will see some resemblance with things that I'm doing today. It was a community-based study located in Gila River community in the reservation. They were conducting since 1965 biennial examination on the entire population starting at age 5, collecting all the data that you see here, demographic, body size, glucose tolerance, eye, kidney, heart disease, mortality surveillance, a pregnancy sub-study, and they had accumulated a ton of data. They're still writing papers today after the study ended in 2007. So what did I do there? Given my passion for youth onset type 1 diabetes, I was intrigued by the fact that they also had a lot of youth onset diabetes, but their diabetes was different. It wasn't what we call juvenile diabetes in Europe. It was type 2 diabetes, a new form of diabetes in kids that we used to call adult onset diabetes. So that was intriguing. So I I had the opportunity to work on this topic. And one of the first papers that I wrote there, and it's one of the first paper that is a population-based study of youth onset type 2 diabetes, was this one highlighted here, in which we showed that over a short 30-year time period, there was a doubling, tripling, or even quadrupling of the prevalence of youth onset type 2 diabetes, adult onset diabetes in the kids in this population, which was really a phenomenon that the world had not heard about yet. And then the question was, why are they having so much type 2 diabetes? Of course, this is a population with a lot of overweight and obesity in both kids and adults. So obesity is definitely contributing to this. But what I was most interested about was to explore this relationship between exposure to maternal diabetes during pregnancy and type 2 diabetes in the offspring in this population. And what you're seeing here is that most type 2 diabetes in kids in this population happens in those people, in those kids who are exposed to their mother's diabetes during pregnancy, type 2 diabetes or gestational diabetes. And this exposure to maternal diabetes in utero was the strongest single risk factor for type 2 diabetes in kids in this population. Well, of course, one of the questions from the scientific community was, this is genetic susceptibility transmitted from mother to offspring. No wonder, it's a population with high genetic risk for type 2 diabetes. So what we did, of course, with the help of my mentors and my colleagues there, was to show that that's not entirely true. So we conducted one of the first SIB pair studies in which we selected pairs of siblings who were born before or after their mother developed diabetes. On the left side of the slide, you see that among 28 such pairs of siblings, in 21, the 28 pairs, the sibling that got diabetes was born after the mother was diagnosed with diabetes. And in only 7 of the 28 pairs, the sibling with diabetes was born before, for an odds ratio of dissociation of 3, which is still a very substantial odds ratio. This analysis isolates the genetic predisposition to type 2 diabetes because siblings inherit a lot of the similar genes from their moms. So it indicates that there's something above and beyond genetic susceptibility and maybe above and beyond familial lifestyles and environmental exposures, because these are siblings that are raised in the same household. So it isolates a specific intrauterine effect. And when we looked at SIB pairs born before and after their father was diagnosed with diabetes, we did not see the same association, suggesting again that this was not a chance finding, that this was not a birth order effect, that there were specific intrauterine effects at work. What we call now programming in the field of early life determinants of chronic disease. And that's when we generated this transgenerational vicious cycle by which diabetes begets diabetes in the next generation with, of course, inputs from the postnatal environment. So what did I learn after this experience, transformative years in Arizona? I learned about type 2 diabetes in youth, a new condition caused by harmful changes in contemporary environments. I learned that exposure to diabetes in utero is a major risk factor and that this exposure has specific intrauterine effects, the programming effects, and that they contribute to what we call now fetal overnutrition, above and beyond genetics. It also solidified my passion for research, enough for me to emigrate from Romania and move to the United States. It inspired a passion for community-based and longitudinal studies, which I had not been exposed to in my home country. And it highlighted for me the importance of Lifecourse research, although this was still not a formed idea at the time. So after this, I had the opportunity of a new beginning by joining the University of Colorado Health Sciences campus. For those of you who have been here long enough, you might remember our location on 8th in Colorado. And I also want to highlight another mentor the person who hired me, who mentored me, who gave me the opportunities that I didn't have before, Dr. Hammond here with us. The reason I joined Colorado, other opportunities that I had, was specifically to work on diabetes research, because this was the place to be if I wanted to do that. So thank you, Dr. Hammond. What did I do? I started defining the research themes that I was interested in and developing human longitudinal cohorts, thinking about the Pima Indian model. So diabetes in youth remained a passion, type 1 in Romania, type 2 in Arizona. So I became part of the search for diabetes in youth, which was a study that was one of the reasons I came to Colorado and continued for 20 years. Developmental origins of obesity and type 2 diabetes, which we've accomplished with the search case control study, the EPOC study, the Healthy Start cohort study, and its participation in the ECHO consortium. And finally, diabetes prevention throughout the Lifecourse diabetes prevention program, Tribal Turning Point, and Enrich. I'm going to touch base on all of these studies briefly if I can. So, burden of diabetes in youth. At the time I joined the University of Colorado, we had limited US data on this. Most data on type 1 came from Europe, and there were no data on type 2. But the world was seeing an increased incidence of autoimmune type 1 diabetes, and there were reports here and there, including my study in the Pima Indians, about adult onset type 2 diabetes in youth. So the CDC and NIDDK decided it was time to have a solid, robust study in the United States. So they funded a search study who was going to expand surveillance to a large geographic area in the United States to monitor trends, all types of diabetes in all racial ethnic groups, develop projections, understand clinical presentations, and provide better data for healthcare planning. And Search did that for 20 years. This is how the search study looked like. It was a multi-center study in many parts of the United States. Colorado was the largest site because we covered the entire state. And then we also worked with American Indian reservations neighboring our state. Search was a 3-in-1 study because it conducted surveillance of diabetes risk, prevalence, and incidence, projections, trends. It had an inception cohort nested within the registry that was followed for more than 13 years to look at complications, comorbidities. And it had a mortality component because we conducted mortality surveillance by linking the registry with the National Death Index, again, providing data on mortality in youth onset diabetes. Just some selected findings from Search. Early in the search history, we published data on incidence of type 1 on the left and type 2 on the right side of the slide, diabetes in youth in the United States. And you can see here different colors because data are presented by age group and by race ethnicity. And for type 1 diabetes, you see that the peak incidence is in children aged 5 to 9 and 10 to 14. And incidence is much higher in white kids, followed by Hispanic kids and Black kids, and very low in Asian Pacific Islander and American Indian children. On the right side of the slide, you see incidence of type 2 diabetes. Remember, this is adult onset diabetes in the kids. Incidence is highest in the oldest age group around puberty, but this was a disease that happened only in adults until 30 years ago. And it is highest in American Indian and Black kids. But you see the scales are the same. And in some racial ethnic groups, the incidence is higher for type 2 diabetes than for type 1 diabetes. Isn't that concerning, surprising? The other thing we provided in Search was a first paper on rising incidence of both type 1 and type 2 diabetes in US youth. Again, on the left, type 1 diabetes, the average increase over a 20-year period was 2% per year, with the rates that were higher and the trends were higher in non-Hispanic white, Hispanic, and Black kids. And interestingly, the trends were higher in Hispanic and Black kids than in white kids. Think about that. This is a disease of European children. On the right, trends in type 2, an average increase per year of 5.3%, almost double that of type 1. And the rates and trends are highest in American Indian and Black children. Now, type 2 diabetes in youth is related to obesity and overweight. So it's environmental, right? Type 1 diabetes? One of the things that we did with search data linked to an older Colorado IDDM registry with a student of ours, Kendra Vihik, who is now a professor of epidemiology in Florida and leads diabetes trials, was to look at how the proportion of high and low risk HLA genes, the genes that predispose to type 1 diabetes, has changed over time in kids diagnosed with type 1 in Colorado. So on the left, you see a decreasing trend of high-risk HLA genes over time in both white and Hispanic kids. And on the right, you see an increasing trend of moderate to low-risk HLA genes for type 1 diabetes in white and Hispanic kids diagnosed with type 1 diabetes, suggesting that in spite of a rising incidence, we see a lower need for a strong genetic predisposition for the disease because the environment is more harmful. And exactly how the environment is more harmful, we still don't know after almost 15, 20 years, but we're learning. Last thing from search that I want to show is why we care about these numbers and trends and rates. And these are data showing the prevalence of diabetes-related complications and comorbidities by diabetes type and by race ethnicity. Diabetes type 1 is in light blue, type 2 is in dark blue. Various complications are listed here: retinopathy, nephropathy, neuropathy, arterial stiffness as a measure of vascular disease, hypertension. And what you can see here is that for each of these complications, the prevalence is higher in youth with type 2 than in those with type 1 diabetes, and especially so in the kids who are not white or other than non-Hispanic white. So that's really concerning. And 1 in 3 youth with type 1 and 3 in 4 youth with type 2 diabetes had at least one complication. And some had more than one complication after an average diabetes duration of about 9 years and an age of about 23 years. So to summarize this part, we learned about an increasing incidence of both type 1 and type 2 diabetes, especially in type 2 and minoritized youth. Changes in the environment in which these children are born and grow are the likely causes. High burden of complications, again, in type 2 and minoritized youth. These shifts suggest higher costs and greater societal burden in the future. And we need to understand and develop effective prevention approaches, which brings me to my second area of interest: developmental origins of obesity and type 2 diabetes. And this area of research is framed around the DOHAD hypotheses, or which postulates that a variety of exposures or stimuli, such as smoking, maternal conditions, social environment, nutrition, toxicants during sensitive periods of development, such as pregnancy and early life, lead to health or disease at the population level. And such sensitive or critical periods exist not only in utero, but also in early life, early childhood, late teen years, during puberty, and pregnancy, again, thus perpetuating that vicious or virtuous cycle of health and disease. So you've seen the slide about exposure to diabetes in utero being the strongest risk factor of type 2 diabetes in Pima Indians on the left. 10 years after that, I conducted a similar study in search case control study, Colorado and South Carolina, and saw exactly the same association in white kids, Hispanics, and Black kids. So this is not an isolated phenomenon in an isolated population at high risk of diabetes. This exists across all populations. And why do we care? We care because of the public health impact of this association. So what you see here is in Search CC, Search Case Control Study, we created mutually exclusive exposure categories in utero to diabetes, to obesity, to both. Assess the strength of associations, the risk for type 2 diabetes in the offspring on the left side of this slide. On the right, we calculated population attributable risks. What proportion of type 2 diabetes in the offspring is due to this exposure, to maternal diabetes, to maternal obesity, to both? And by summing up those fractions, we calculated that if these associations are causal, almost half of youth onset type 2 diabetes is due to exposure in utero to maternal diabetes or obesity, to fetal overnutrition. Not all, but half is a lot, which also means that if we could treat or prevent these conditions, maybe we could prevent half of type 2 diabetes in children. But of course, genetic predisposition is important. But where is genetic predisposition important? So in this more recent study in the EPOCH cohort, we used a genetic risk score for type 2 diabetes and looked at its association with fasting glucose and 2-hour glucose in children and adolescents. And what we saw here was joint effects of genetic predisposition and exposure to diabetes in utero. So in those who were not exposed to maternal diabetes in utero, really by this age, there was no major effect of the genetic risk score for diabetes on fasting glucose or 2-hour glucose. On those who were exposed in utero to maternal diabetes, having a genetic predisposition increased their glucose levels, precursor of diabetes. So maybe what is the reason we're seeing type 2 diabetes here in kids is an interaction, a joint effect of exposure to diabetes in utero and genetic predisposition. But we wanted to move beyond. I wanted to move beyond exposure to diabetes in utero to see if there are other factors during development that predispose kids to adiposity and metabolic disease, or factors that protect them. And so one of the directions I took was to create a pre-birth cohort, which started in 2009 by recruiting pregnant women who were going to deliver here on campus. And we successfully recruited 1,400 moms who delivered here. We followed them through pregnancy in collaboration with our colleagues from OBGYN and all the OBGYN clinics here on campus, and then followed them from early pregnancy to through delivery and into childhood. We continue the follow-up of this cohort. Now they are 10 to 15 years of age, and hopefully will continue into the future. Here, the main exposures of interest were in utero and early life maternal conditions, diabetes, obesity, but also lifestyle, diet, physical activity, environmental chemicals, big area of interest, air pollution, built environment. So both under the skin and above the skin type of exposures. We also wanted to collect samples from moms, from offspring, and samples at birth to explore the biological signatures of these exposures. And so we collected such biological samples. And then in terms of outcomes, we were interested in a myriad of outcomes, including childhood growth and development, adiposity, metabolic outcomes, cardiovascular outcomes, brain development. We have brain MRIs on these kids. We have abdominal MRIs on these kids, neurocognitive and behavioral factors. And now this cohort is part of the ECHO consortium, and it's furthering its impact by collaborating with other similar cohorts across the United States. One of the things we wanted to focus on in this cohort was assessing body composition. So not just body mass index, which is good for certain things, but going deeper into things that are really more sensitive measures of adiposity. So we measured body composition with air displacement plethysmography, device called PPOD, or later in life BOD-POD. And you see here pictures of these measurements, or we have this spaceship for kids in our center. We decided to do this, and we're one of the few cohorts that has longitudinal markers of body composition throughout the life course, because this is a sensitive marker of abnormal in utero environment. For example, infants of overweight and obese mothers have greater fat mass than normal weight mothers, but they have the same amount of fat-free mass and the same birth weight. Well, if this is a more sensitive marker of the intrauterine environment or intrauterine exposures, because it picks up things that affect specifically fat mass, is fat mass at birth predicting anything? And indeed, it predicts childhood obesity, another interesting novel things that we've demonstrated in this cohort. So that each 1 standard deviation increment in neonatal adiposity is associated with an increased BMI and a 20% higher prevalence of overweight obesity throughout childhood. So we can use this marker at birth for specific intrauterine environments in studies or trials where we want to prevent childhood obesity. So we have a biomarker of childhood obesity at birth. Very selected findings from Healthy Start study. I cannot show you all because we have published over 100 papers. So I picked and choose. So I'm sorry to those of you who are co-authors and I didn't pick yours. I just wanted to highlight a little diversity of things that we studied. So we found that maternal obesity and gestational weight gain independently of each other influence neonatal adiposity, fat mass at birth, which is important because then one can design intervention focusing on both pre-pregnancy BMI or gestational weight gain. And then in vitro, with collaboration from our basic science colleagues, they looked at mechanisms responsible for this association and found that the relationship between maternal obesity and neonatal adiposity may result from greater lipid accumulation, lower fatty acid oxidation, and suppress AMP kinase activity in mesenchymal stem cells. I'm going to say what those are later. Maternal healthy diet assessed with an index called Healthy Eating Index and physical activity are protective against neonatal adiposity, fat mass at birth, without influencing fat-free mass or birth weight. So this mantra that pregnant women need to eat for 2 and they need to be at bed rest is not true. They need to exercise and they need to eat healthy and not gain too much weight. Because then they'll have babies with normal birth weights, but less fat mass. We also learned that maternal glucose is associated with offspring glucose. Now, we've seen this, that maternal diabetes is associated with childhood diabetes, of course, but this goes into normal ranges as well. So children of women in the highest versus the lowest tertile of hemoglobin A1C had higher fasting glucose at age 4 to 7. But interestingly enough, adjustment for fat mass at birth at 4 to 7 or cumulative fat mass over this period did not change these associations. So this association between maternal glucose and childhood glucose is not completely mediated through adiposity. So this is another thing that our basic science colleagues are working on to understand the mechanisms responsible for these associations. We also learned that maternal metabolomics identifies pathways to offspring obesity in early childhood. And these pathways are related to lipid, oxidative stress, inflammatory pathways, which is interesting because they can offer potential therapeutic targets. But back to public health, we also learned another somber thing, that ideal cardiovascular health, which is a composite score that includes several clinical and behavioral metrics, is low in contemporary youth. And it's low not because they have high glucose or high blood pressure. It's low because they don't eat well and then they don't exercise well. Diet and physical activity are the limiting factors. On a positive note, a healthy pre-pregnancy BMI and male sex are positive correlates. This might explain why type 2 diabetes is more frequent in girls. Sex differences. In the Healthy Start cohort, via the ECHO funding, we were able to expand our research into environmental health exposures and establish numerous collaborations here. The focus here was on early life chemical, physical, and social environment, and their influence on the development of adiposity and metabolic disease. So we developed models of air pollution via collaboration with Colorado State University colleagues, Cheryl Magsamen here. Models of traffic-related air pollution, PM 2.5, ozone, black carbon, using GIS data and regulatory monitors at various households. We collaborated with CU Boulder to look at effects of green space and the built environment. We collaborated with Brianna Moore is a faculty in the LEAD Center to explore in more depth the effects of tobacco smoke during pregnancy and early life, including secondhand smoking and also exposure to cannabis in utero or in early life. And then with Ann Starling, who used to be a faculty here, but now moved to UNC Chapel Hill, still collaborates with us. We're looking at widespread chemical exposures via drinking water, consumer products, such as PFAS, urinary phthalates and phenols, organophosphate flame retardants and metals, and many others. And here are some papers from these collaborations: secondhand smoke, breastfeeding and infant adiposity, predictors of phthalate exposures in women in Healthy Start, PFAS and infant growth and adiposity, and one interesting paper in which we looked at combined environmental and social exposures and their effects on growth. One of the most interesting opportunities we had to do in the Healthy Start cohort was to expand our collaboration with our basic science colleagues, again, with funding from ECHO, and study those programming mechanisms that I was referring to earlier in my talk. So here the goal was to measure molecular signatures associated with in utero, metabolic, lifestyle, environmental exposures to determine biological pathways that link these exposures to health outcomes in the offspring. And so we collected biological samples, such as umbilical cord tissue, placenta. From cord tissue, we derived infant mesenchymal stem cells, and we measured a bunch of omics to study mechanisms. And I'm highlighting, again, a few studies. Some conducted in Thomas Jensen's lab. These are placenta studies in which, from diverse healthy women across the BMI spectrum, normal weight, overweight, obese women, the hypothesis was that they will identify placental proteins linked to childhood cardiometabolic traits. And indeed, they found that proteins involved in mTOR, MP kinase, inflammation, insulin signaling are linked to cardiometabolic traits at 4 to 6, including triglycerides, skin fold thickness, and others. And now they're interested in identifying what maternal exposures are affecting these placental proteins to really explore the entire mechanism. Very interesting here, work conducted by Kristen Boyle in the Department of Pediatrics with mesenchymal stem cells collected by the Healthy Start cohort. So we had this idea of collecting fresh umbilical cord tissue at birth, not via the originally funded grant, just an idea that occurred to us. And 165 mesenchymal stem cells were isolated, grown, and stored for future use. These cells are primordial cells that have the capacity to differentiate into all cells into the body: adipocytes, myocytes, chondrocytes, astrocytes, everything. And our basic science colleagues, led by Kristen Boyle, are using these in vitro in their labs to look at mechanisms responsible for associations between exposures and outcomes. For example, they found greater adipogenesis in MSCs from obese versus normal weight mothers, mediated by this beta-catenin system, and that DNA methylation in MSCs correlates with percent fat mass at birth and fat mass during childhood. Kristen Boyle has taken this area of research into numerous other directions. She got ADA grants, R1 grants, and she's continuing her collaboration with the Lead Center, and we're extremely proud and grateful of her work. Our work in Healthy Start is used also by the ECHO Consortium. And this is just an example of a paper relevant for those of us in public health, where with 20,600 children from 54 cohorts in the ECHO Consortium, Izudin Aris, a colleague from Harvard, and some of us looked at the association between childhood opportunity index, neighborhood index of physical and social characteristics of the neighborhood environment is associated or not with growth throughout childhood. And they found that higher childhood opportunity index at birth predicts lower mean body mass index in childhood. And the strength of this association increases with age at BMI measure. So demonstrating that physical and social characteristics of our environments influence how children grow and their obesity risk. The postnatal environment is still important. A lot of what I said until now only focused on the prenatal in utero environment, but the story doesn't end at birth. We were always interested in seeing if children who are exposed to maternal diabetes in utero, maternal obesity in utero, or certain harmful exposures are doomed. And they were not. So this paper shows that, for example, a healthy diet later in life, in the postnatal life, breastfeeding, modifies the effect of exposure to diabetes in utero. So what you see here is body mass index of children from the EPOC study, 10-year-old children who were exposed in red and not exposed in yellow to maternal diabetes in utero. And those who were breastfed that's less than 6 breast milk months, there is a significant difference in the BMI of those exposed and the BMI of those not exposed, a much higher BMI in those exposed. Left side of the slide. Right side of the slide, those who were breastfed for at least 6 breast milk months, there's no such association, suggesting that the children exposed to harmful intrauterine environment, they're not doomed for life. We can do something in the postnatal life to mitigate the risk conferred by that intrauterine environment. And is it breast milk? Is it breastfeeding as a bonding behavior? We don't know yet, because we repeated this analysis with childhood diet at ages 10 or older, and we found the same thing. Upper side of the slide are children whose healthy eating index was low, who had at age 10 an unhealthy diet. And in those children, those exposed to diabetes in utero had much higher BMI, waist-to-height ratio, visceral adipose tissue, subcutaneous adipose tissue than those unexposed. But in those who had a healthy eating index at age 10, who ate a healthy diet in life, these associations were not significant. Again, suggesting it's a healthy postnatal environment that mitigates the risk conferred by a harmful exposure in utero. But most US youth do not meet recommendation for healthy eating or physical activity, as I've shown previously with a low ideal cardiovascular risk health score, unfortunately. So, summary of this part, Pediatric obesity and youth onset type 2 diabetes have strong developmental origins. Almost half of youth onset type 2 might be the consequence of overnutrition in utero, and genetic predisposition amplifies this risk. But postnatal life modifies the long-term consequences, and postnatal behaviors may reduce risk. But most youth do not meet recommendations for healthy eating and physical activity, further contributing to childhood adiposity and type 2 diabetes. So what can we do? Times have changed, right? What can we do? I think we need to think about prevention throughout the life course. And of course, we have strong evidence that diabetes can be prevented in adults. And this is the landmark diabetes prevention program and its outcome study, DPP and DPPOS. That was started by Dr. Hammond here in Colorado, and it's continuing by me. This was a randomized trial of 3,000 overweight adults with impaired glucose tolerance, very high risk for type 2 diabetes. They were part of the trial with two interventions, one intensive lifestyle intervention aimed at reducing their body weight by at least 7% through healthy diet and physical activity. And metformin, which is a drug that is used to treat diabetes, but it was used here in people without diabetes at high risk versus a placebo. And they were followed for 3 years in the active trial. The trial was stopped early because of amazing effects of both interventions. They reduced diabetes risk by 31% metformin, 58% lifestyle. And now we're following this group into the DPPOS, the observational arm of the trial. An economic analysis that was conducted during trial and afterwards showed that metformin was cost effective. Those who are interested in telling the governor, for example, how we can save taxpayer money. Here's an example. Metformin was cost effective and lifestyle was cost saving. And now, as a consequence of this landmark trial, Medicare covers a DPP-based in lifestyle intervention for diabetes prevention, but participation is not great. In the trial and throughout the observational phase of it, heart disease and stroke risk factors were also reduced with fewer medications, just as a consequence of that intervention. And in the last two phases of DPPOS, we followed this cohort for diabetes-related complications, cancer, and now Alzheimer's disease and related dementias. And we're seeing interesting things, although these interventions did not prevent complications of diabetes and did not prevent cancer, they prevented diabetes, and people who didn't develop diabetes had less cancer. So it's interesting. Maybe we need more time, or maybe we need to analyze the data in a different way. I think the message is very positive here. So have we turned the corner? These are data from the CDC that show incidence trends for diagnosed diabetes among adults aged 20 to 79 in the United States from the 80s to 2012. And they show that after a period of increasing incidence of diabetes in the United States, around 2008, there was a plateau or there was a decreasing trend. And of course, we put DPP there to kind of highlight why we're seeing it. It could be. So maybe we're seeing a decreasing trend of about 5.4% per year, which is great. Remember the figure I showed you about increasing trends in childhood type 2, 5.3% increase per year. So type 2 diabetes can be prevented in adults. Positive, strong message, important message. But obesity and type 2 are increasing in youth. Pre-birth and early life exposures influence adiposity and diabetes throughout the life course. So I think we need earlier interventions. An example of such interventions that we're doing in the LEAD Center is shown here, the Tribal Turning Point, which aims at improving postnatal behaviors in very high-risk populations. This is a DPP-based group intervention among 300 American Indian children. age 7 to 10, prepubertal, ongoing since 2012. That includes 12 group classes with physical activity, interactive learning, meals, culturally appropriate, 7 individual motivation interviewing sessions to build problem-solving skills, to reach behavioral goals, and a toolbox with general and local resources. And in a pilot study that preceded the launch of the larger trial, we conducted a randomized pilot study in 62 youth in 2 tribal nations. And what you're seeing here is that even in the pilot study, we saw positive results. The before-after BMI, Z-score, waist circumference in the intervention group versus the control group are significantly different. The intervention was extremely effective. So if indeed an intervention like this is effective, it can be disseminated, scaled to a larger American Indian population. It can be translated to other groups such as rural children and other groups that are underserved. So I think this also has a lot of potential. We're also proud to participate in another consortium called ENRICH, Early Intervention to Promote Cardiovascular Health of Mothers and Children. This consortium aims to promote maternal and infant cardiovascular health. And there are 7 clinical sites that were funded. Each of them had to partner with federally approved home visiting nurse-based home visiting programs to support over 4,000 pregnant women. And the focus is on life's essential aid that I referred to earlier. So healthy diet, physical activity, normal glucose, normal weight, low lipids, normal blood pressure, no smoking, and adequate sleep. And our side, the Colorado Enrich side, led by our colleague and collaborator, Mandy Allison in the PRC and Accords Center, is working with nurse family partnerships at Denver Health to recruit participants and deliver the intervention. This is just starting. Stay tuned. Okay, so the last part of my long talk is going to focus on I don't want to say the 4th part of my career, the current part of my career, which focuses on building my legacy. I think you've seen themes that carried throughout my presentation, and I think they all culminate in this, what I call legacy, building the Lifecourse Epidemiology of Adiposity and Diabetes, the lead center. And what I think it's important and unique about the center are several things. First of all, from the beginning, this was designed to sit across schools and across departments. So the major stakeholders and proponents and contributors to the center were the Department of Pediatrics and Children's Hospital, and my gratitude goes here to Dr. Steve Daniels, who said he was going to be present here, but maybe he can't come. And School of Public Health with strong and enthusiastic support from the Chancellor's office. And I'm also extremely grateful for the support at the initiation of the center and throughout the years. And next year, we will celebrate 15 years of existing. So thank you very much for your support. In the center, we want to identify environmental, structural, biological, genetic determinants of obesity, diabetes, and associated conditions throughout the life course with the focus on prevention. Why I think it's innovative, it uses a life course research framework. It draws upon resources that we've created, population, longitudinal human cohorts spanning the life course. It is collaborative and multidisciplinary. It provides training and mentoring to junior faculty, fellows, students. And it focuses on impact, translating the findings into preventive action. And just very quickly, what is the life course research framework? Most of you may think of it by just looking at this x-axis, the longitudinal axis here, that it happens throughout the life course, starting with preconception, conception, early life, and going on. And that's an important component of it because Chronic disease and risk factors for chronic disease don't just happen. They have a long history. And it starts with things that happen during periods of high plasticity and high reversibility, when if you intervene, you can change trajectories into the positive directions. And if you wait until the risk factors are ingrained or the disease has already started, it's much harder to change things. But this framework also has a vertical axis, and it talks about the importance of the multi-level environment and how things influence each other and how we need to have this holistic view when we try to prevent or cure disease. Because things interrelate, metabolism, physiology, growth, family factors, community factors, structural factors. And without that view, we're not going to be successful. Lead at a glance, I need to mention a few numbers here and a few things. We have these large longitudinal cohorts that I've mentioned. They're used to also study mechanisms. With them, we participate in national and international consortia, and there are some that I haven't mentioned yet, but they're listed here. We conduct population-based surveillance, which is important because we need to know what happens at the population level with the diseases that we study via our interventions, for example. Clinical trials and translation of those clinical trials into effective community prevention programs. Since inception of the LEAD Center, we submitted 164 proposals, 90% of federal sponsors, 53 funded programs, a 32% funding rate. For those of you who live in your own world, this is a very high funding rate. Our funded projects took over 44 million, generating a lot of indirects, and we trained many students, postdocs, and junior faculty since inception. The LEAD Center is now located in the newest and most beautiful building on campus. And you see a picture of our front room here. We currently have 66 members. Most of you are here. 29 active grants belonging to 11 core faculty with appointments in pediatrics or the School of Public Health. And our grants provide full or partial salaries to our faculty, staff, and students. What's going to happen in the future? I call these LEAD research priorities. But what I really hope is that my colleagues that are now joined me in the center will take this over and multiply it by an N of 11, 15, and build upon this and make this the next Barbara Davis or the next Cancer Center or the next, you name it. But some of the things that we are all engaged in are systematic and sustainable surveillance of pediatric obesity and diabetes, as I said, to understand burden and risk, effective prevention programs, development and burden of complications, and mortality. And here, my colleague Tessa Krum is championing this area. To identify predictors of youth onset type 2 diabetes, we participate in another consortium focused on that. And here, my colleague Wei Peng is leading this area. To remove disparities in vascular outcomes of type 1 diabetes. This is a new search grant just funded across 3 sites. And here, alongside with me, my colleague Janet Snell-Burgeon from the Barbara Davis Center and Rebecca Conway from the Department of Epidemiology are leading this direction. We need to continue to invest in longitudinal pre-birth or birth cohort studies and consortia of such studies to explore comprehensively the role of environment, the exposome, and their biological signatures, and identify possible potential causal associations with health and disease. And here my colleague Tracy Beckelman is now taking the lead on the Healthy Start ECHO Consortium collaboration. And I'm proud to say that we are starting a new pre-birth cohort study in collaboration with Denver Health, and my colleague Brianna Moore is leading that effort. We need improved understanding of mechanisms, as I described previously, and here my colleague and collaborator from the Department of Pediatrics, Dr. Kristen Boyle, is taking the lead. And we very much need effective interventions, randomized clinical trial and translations of these studies to break the vicious cycle at multiple levels and also focus on primordial prevention, preventing risk factors for even occurring. So this was the last slide. Thank you very much to the Lead Center for all their work in the studies that I've presented. Again, thank you all for nominating me and giving me this award. And thank you, Dr. Flake and Don Alleman, for all your trust and confidence in me. Thank you.
Very well done. Fantastic. There's not many researchers that can say for this particular project, I'm going to have a few selected highlights from the 100 publications associated with it. So it's very impressive. We've got a little bit of time for questions if there's any questions in the crowd.
Just amazing. As a former exercise physiologist, and focused on exactly what you're putting the longitudinal studies on. I'm just amazed at the work you've done, and it just solidifies the work that people in that field are trying to do and get ahead of this. One of the things that popped in my mind when you were talking about the environmental collaborators was on the chemical side. Did you look at endocrine disruptors at all? Because man, that's just a gigantic basket.
Thank you. Okay, thank you for those comments. And that was one of the bullets on one of the slides, work conducted by Anne Starling on environmental chemicals, PFAS, phenols, metals, etc. And she's finding associations with birth weight, with fat mass at birth, with childhood growth, with a variety of childhood outcomes, including reproductive outcomes, because they are known to affect hormonal changes in children. Yes, this is an area of intense interest, and the whole ECHO consortium, if you want to see how many papers focus on environmental chemicals, it's probably the largest group of papers. So we're gonna dissect this left and right.
Fantastic. Any other questions? In the back, there you go. Get my steps in today. No, that's fine. There you go.
Amazing talk. Thank you so much. I have two related questions. One, do you know if maternal alcohol maternal alcohol consumption on the baby, like, does that have any impact on the predisposition for diabetes? Maternal, like.
Okay. Thank you for the question. We have collected alcohol consumption during pregnancy in our cohort. It's not high, but neither is smoking, and smoking has a lot of influence on birth weight and offspring growth. But alcohol consumption, we did not see any important associations. It's still wise to advise pregnant women to not exceed a certain amount of alcohol. Interestingly, I'm expanding on your question. We did see associations between cannabis consumption during pregnancy or exposure to cannabis in utero and growth, as well as glucose levels in the offspring, work led by my colleague, Brianna Moore, who's here, but I'm not seeing. Hello, Brianna.
The second question was like, people who have gestational diabetes, can they develop diabetes towards later age, or does the age of being motherhood dictates the chances of diabetes?
Okay. Sorry, accent is hard. Whether the age of the mother interacts with the gestational diabetes as a risk factor for offspring type 2 diabetes. Frankly, I have not seen that in publications, either in the Pima Indians or other studies. Maternal older age has influences on offspring health for sure. So I wouldn't be surprised that there is a joint effect.
All right, any other questions? All right, well, let's do another round of applause for outstanding excellence. Okay.